Hello, everyone. Hello. Hello. Hello.
Yes, Dr. Sunil.
Hi, Anishwar here. Good afternoon. Sandeep is about to join in 2 minutes. He will join. I had some problem with Zoom software, I think, or desktop was not working, so I'm on the mobile now. Okay.
No problem.
Uh, we'll start in 2 minutes. Yes.
Sure, sure. Yeah. We'll wait for 2 minutes and then we'll start.
Yeah. I think we shall start now. Okay. So again, today again, this weekend, Saturday, I'll welcome all of you on the behalf of State NNF chapter, Maharashtra State NNF chapter. And today again, we have one of the young, talented, very uh, aggressive sort of Virat Kohli of NNF, we can say Maharashtra NNF. We have called him second time on demand, basically. Our president specifically asked me to call you, sir, Anish sir. He's actually a consultant and he has done his neonatology training. After that, he had opportunity to do work abroad, and now he had joined Surya as a consultant, a neonatologist. Uh, and as I said, it's very like as a young academic person, and it we will always like will have some benefit to listen to him. Let's hand over to Sir Anish sir. Please take over.
Thanks. Yeah, thank you, Sunil. I'll just start sharing my screen first so that it's
Yeah.
visible.
Yeah.
Is it now visible to
Yes. Yes.
everyone?
Yes. 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 Make it PowerPoint.
Okay.
Okay.
Yeah,
Done.
so I have chosen a topic that is very common for practicing pediatricians, and transition is something that we take for granted many times because it happens for 99 out of 100 babies have a very smooth transition. Yet that 1% of the times where the transition doesn't happen, we are often caught off guard. So hopefully, through after this talk, we will be a little bit more aware about the common transition problems, and so I have presented both challenges and solutions. So the objectives of today's presentation are to understand the mechanisms involved in transition from fetal to neonatal life and what could go wrong in this transition process, identify delayed or abnormal transition very early so that we can act in time, and prevention and management of a problem. So the good news first, like I said, the good news is that nature's mechanism of transition is very robust, and out of 100 times, probably 99% of the times things will go smoothly. Although we need to be cautious. So just one word in terms of this topic. Who am I? In terms of a neonatal transition, I'm always very suspicious. So I'm a very suspicious neonatal physician, almost like a detective, trying to find things if they are wrong in transition or not. But what is the balance? What is the right balance about being paranoid and proactive? So hopefully after this talk, we will, get a right balance how suspicious we should be, but also, not separate the baby from the mother without any reason. So we'll go through for some common case scenarios, and through the case scenarios, I'll try to highlight and discuss the common transition problems. So case number one, this is baby R. This baby was born at 36 weeks and 5 days. So a late preterm baby born to a mother with pregnancy-induced hypertension. A C-section was done because the baby was breech and the mother was very anxious to push for a normal delivery. The baby had a reasonably good weight, 2.7 kilo, and the baby cried after birth. Apgar scores at birth were 7 and 9. At 15 to 30 minutes, they noticed that the baby had grunting while crying and the extremities were cool. And then SpO2 was checked, which was 95% on room air. So the SpO2 was acceptable at that point. However, at 2 hours, the grunting persisted. There was some nasal flare. The SpO2 was 93 on room air. The pulses and BP were normal. But because of the grunt, the physician teams thought that let's start some oxygen, because at 2 hours also the baby is grunting. So the baby was watched very closely and started on low flow oxygen. So at this point, let's take a pause and think about this baby who's 2 hours old. So is this normal transition or abnormal transition? That is the first question that we need to think. Secondly is that when do we intervene? So this, in this particular example, low flow oxygen was started, but was that the right decision? Was it necessary or was something more necessary? Third question is what intervention? So they have decided to intervene at 2 hours, but what intervention is ideal? Whether it's low flow oxygen, observation, CPAP, ventilation, what, and how do we plan or anticipate for the worst case scenario? Because that is always the thing that we need to sort of keep in mind. What could go wrong and how quickly things could go wrong. So again, coming back to the scenario, low flow oxygen was started, and at 6 hours, they noticed that the work of breathing is further increasing. SpO2 is now 85% despite low flow oxygen. The baby looks a little off color and the grunt is now persisting. The blood gas was done at 6 hours, which shows respiratory acidosis, pH of 7.12, PCO2 of 78, PO2 of 45, bicarb of 26, and base excess of -7. So primarily respiratory acidosis was seen. And then obviously an X-ray was done at that point, and this is what the X-ray picture showed. So the arrow is showing a fissure, but also there is some haziness overall. So it is, the newborn X-ray at birth is a relatively non-specific. So it looks like probably TTN with some component of RDS, and infection obviously can't be ruled out in any of these cases. So the infant was then started on CPAP with the PEEP of 6 and an FiO2 of 40%. And on the CPAP, slowly the distress settled down. Because infection was a possibility, antibiotics were started, IV fluids were started. The baby improved clinically after 48 hours. Rice tube feeding was started on day 2 and reached full feeds by day 4. And then finally the discharge happened on day 12. So this baby, which was initially seeming relatively okay, by 1 hour, 2 hours, ended up needing a 12-day stay in the NICU. So coming to the first part of neonatal transition, which is the most important, is the fetal lung fluid clearance. So on the left side, as you can see, the fetal lung, the membrane, the epithelial membrane is secretory, and the sodium chloride channels, they sort of secrete actively fluid into the alveoli. And this fluid sort of mixes with the amniotic fluid in the fetal life. What happens during delivery is that, especially for normal delivery, due to active labor, the baby sort of know that delivery is going to happen. So a lot of hormones get secreted, primarily cortisol hormone in the fetus, and that hormone mainly switches this membrane, which is primarily secretory, to an absorptive membrane. So on the right side, as you can see, the fluid is sort of being reabsorbed by the membrane, the same membrane, and by this epithelial sodium channel, which is the primary channel by which the fluids are reabsorbed. And mostly, by the time the delivery happens, after a period of labor, the baby is already prepared for delivery and partly the fluid is already reabsorbed. So the transition happens more smoothly. In cases babies are born early, especially by a C-section, this sort of normal transition doesn't happen. So previously it was thought that transient tachypnea of newborn, is more in C-section babies, because during vaginal delivery, the lung or the chest gets squeezed and the fluid is sort of removed from the lung. The current concept is obviously that it is mainly related to the epithelial sodium channel, which are from secretory, they become absorptive and they absorb the fluids prior to the baby's birth. And the rest of the fluids are quickly reabsorbed after the baby's birth over a period of few hours. So what all does cortisol do? So cortisol in the mother increases till 36 weeks and peaks during labor. So this peak of cortisol is quite important for the mother and the baby. It helps in lung maturation. It also induces surfactant. So it is also important for surfactant production and surfactant maturation. It clears the fetal lung fluid. It is also important for the functional maturation of the gut. It also regulates catecholamine release, and it controls the energy substrate metabolism. So the glycogenolysis and those sort of cycles which maintain the glucose, we'll be discussing that later, are also somewhat dependent on cortisol. So from this first case scenario, what are the key messages? So if you broadly look at the baby, if you rewind the baby and look at the baby at 2 hours, how do you know whether a transition is delayed or normal? So normally also babies can have a small grunt. They can be slightly tachypnic. But the main key feature of normal transition is number one, that it improves with time. So half an hour baby will be better, 2 hours the baby will be more better, 6 hours the baby will be even more better. So that gradual improvement is the first sign. And the second sign is that normal transition, there should be never any need of oxygen. So if any baby is needing oxygen, it automatically means that the transition is either delayed or it is not going normally. Second point, like I already said, the serial monitoring for the resolution is very crucial. At one time assessment, it is very difficult to say that this baby is going to transition normally or not. So that baby really needs very close follow-up. If abnormal, or if there is suspicion of abnormal transition, at that point we should check a gas and do an X-ray. And another message which is important is that if there is truly a delay in transition in terms of, and the baby has grunting, retractions, or any sign of distress, then a PEEP, when in this case, like we use the CPAP, is preferable to giving a low flow oxygen. The low flow oxygen won't help in opening the lung. The PEEP will help in opening the lung also, and it will also help in absorption of the lung fluid. So let us switch gears and let us come to our second case. This is baby O. This baby again is a late preterm. Mother had GDM, so she was on insulin. Baby was born by cesarean section due to polyhydramnios and preterm labor. The baby had a good weight, 3.2 kilo, and the baby cried after stimulation. Apgar scores again were normal. At 30 minutes, the baby had occasional grunting while crying. SpO2 was 97% on room air, and the baby looked quite pink. Because the mother had GDM on insulin, a sugar was checked at 1 hour and the by glucose sticks, and it showed 19 mg per deciliter. Because it was the first sugar and because it was only 1 hour and the baby was otherwise looking well, it was decided to give a feed. However, they gave it through an RT because there was some grunt, so they didn't want to give oral feeding to ensure that the baby gets the adequate volume. So 20 ml RT feeds were given, and they decided to check sugar after 1 more hour. And after 1 more hour, they noticed that the sugar was 24. So, and again, the baby was asymptomatic at that time. So it was felt that there is a small rise in sugar, and it's increasing with the feed. The baby's otherwise okay. Let's wait and watch with feeds and let's follow up. So after 2 more hours, they gave again another RT feed at which was 20 ml again. So again, let's recap the same questions that we sort of thought for the first case. Does this look like normal transition or abnormal transition? The sugar has been low with the feeds. It's gone up a little bit, but still it is below a satisfactory level. So that is the first question. Second question, again, when to intervene. So we have intervened with feeds, but at what point should we intervene, saying that, okay, no, now the baby needs IV? Should we wait for 2 more hours, 6 hours, 8 hours? How long to wait safely? Again, the next question is what intervention? Does the baby need a normal IV fluid with D10, or do we need a higher GIR? What is the role of other medications like, steroids, glucagon and such? And how do we again anticipate and plan for the worst case scenario? So let's see how the case progressed. So at 6 hours, they noticed that the baby was now dull, jittery. And when they checked the repeat sugar, it had dropped further to 12. At that point, they started looking for an IV. They gave RT feeds, but at this stage, obviously, IV was very difficult and there was panic all around. And at 12 hours, finally, they secured an IV, and then the baby was needing 15% dextrose with a very high GIR to maintain the normal glucose levels. So this is not the baby's MRI, but this is the main worry with hypoglycemia that we have for all babies. This MRI is showing the occipital injury due to hypoglycemia, the hyperintensity that you can see in the occipital region, which can lead to adverse visual outcomes in the future. So let's take a couple of minutes and discuss the metabolic adaptations that the baby or a newborn has from in utero to ex utero life. So during near term, that is around 35 to 37 weeks, the glucose and other substrates are stored as glycogen and fat in anticipation of birth, because the baby, again, with all these hormone release, there is a preparation that is happening for the babies in the baby system, and there is this extra storage of nutrients in the baby's body. Catecholamine release and increase in cortisol are major acute regulators of plasma glucose right after birth. As soon as the baby is born, once the umbilical cord is clamped, the insulin levels fall because the glucose is dropping. The umbilicus or the placenta provides a constant, smooth inflow of glucose into the baby's blood. And the moment we clamp this umbilical cord, that is suddenly stopped. So the glucose levels naturally drop, at 1 hour, 2 hour, and that therefore with that the insulin levels also normally should be dropping. So the umbilical clamp causes a sudden stop in the glucose flow. Baby's production, if it is not induced, it causes a nadir, and usually that induction of baby's own glucose takes a couple of hours. uh, we should remember that there are two types of hypoglycemia in newborn babies. One that is associated with fasting, that usually improves after feed, and then by the time the next feed starts, which is after 2.5, 3 hours, it sort of slowly drops again. And then once after feeds, it again picks up. So that is called as the fasting type of hypoglycemia. The other one is called as hyperinsulinemia, where the insulin levels in the baby's circulation are very high, and whatever glucose you give, no matter what, it will be driven intracellularly. So these babies usually have much lower glucose levels. They also require very high glucose requirements to maintain their normal sugar. So again, this is a preventable problem. With close monitoring, with careful eye, this sort of complications can be prevented. And also this is a medical legal problem, because if there is severe hypoglycemia which is symptomatic, or if there are any long term problems, then the neonatal team could be liable for not monitoring closely. So how frequently should we check? So if the baby is very well, the first sugar check can happen at 2 hours. Feeding must happen before that. So feeding, like we say from WHO point of view, the first feed should be given in 1 hour or within 1 hour. The sugar check can happen at 2 hours if the baby is well, but should happen earlier if this is a sick baby, or if it is a baby who's needing NICU admission, we should check it earlier. Any value less than 25 mg per dl should always raise a higher index of suspicion. We should also confirm it with the lab value if we have checked it with a glucose 6 value or an ISTAT value. Most babies of hypoglycemia, whether it is related to GDM or not, will have a sugar between 25 to 40. So that is usually considered as not very critical. And you can give a feed, you can wait, and most likely it will pick up also. But if the first sugar is 10, 12, 14, that already means that something could be wrong. So have a clear differentiation between the fasting type of hypoglycemia versus the hyperinsulinemia in the neonatal period. And the key thing is that the glucose is the only fuel for the brain, and that's why it's very critical to maintain the normal glucose level for these babies, because none of the other nutrients can be utilized by the brain except for the glucose. So this is just a break slide. I think the cases that I'm sort of going to run through are outliers, but they have happened in real life. Actually, all cases are taken from real scenarios. So again, rather than getting very negative and very worried, we should sort of also have faith that nature does have a really robust way of maintaining transition. In the meantime, we'll sort of also focus on the outliers, or how we can prevent bad events from our side. Coming to the next case, case number 3. This is baby M. 35 weeker or 2.3 kilo. The mother had PV leak for 2 days. The mother had noticed decreased fetal movement, and so a C-section was done. The baby cried after birth, and again Apgar scores were 6 and 10. At 30 minutes, the baby was noted to be a bit cool, hypothermic with dusky peripheries. Minimal distress was noted, and saturations were 92 to 94% on room air. So the baby was initially with the mother only, and then the mother called the nurse saying that the baby's peripheries look a little blue. They warmed the baby, they sort of wrapped the baby nicely, put on mittens, and it seemed transiently that the baby is a little better. At 2 hours, the baby took one pallida feed. There was occasional grunting. Dusky peripheries were still there. Capillary refill was 3 to 4 seconds. And SpO2 at this stage was 90% on room air. But when the baby cried, it seemed that the baby is getting more dusky and more blue. And the saturation was showing around 80 to 85. So again, the question is that this baby sort of is a little bit cold. They've tried rewarming, but it is not working. So is this normal transitional abnormal? Should we just continue keeping the baby with the mother? So when to intervene? Can we wait safely for some more time, or should we just start some support? If yes, then what support should we start? Again, like in our first case, should it be low flow oxygen, or some, the baby needs to be under a radiant warmer or an incubator, or whatever. So these thoughts sort of always come to the mind, and what can go wrong, and how do we plan for the worst case scenario? So they decided to closely observe the baby and keep it with the mother. And at 6 hours, the baby again had mild distress. The distress was never very severe, but again the peripheries continued to be dusky, and SpO2 remained around 82 to 85% despite starting low flow oxygen. So it wasn't very responsive to oxygen. Despite starting oxygen, the saturations didn't immediately pink up, and the baby's peripheries and such continued to be dusky. During crying and handling, the baby's lips and peripheries were turning blue. Again, a blood gas was done. This time it showed a mixed picture, mixed acidosis. So the pH was 7.12, PCO2 was 62, bicarbonate was 15. So it showed a mixed metabolic and respiratory acidosis on the blood gas. And again, this was the X-ray. So again, in this X-ray, you can see the air bronchograms. There is mild haziness. So this looks probably like mild RDS, which has not been treated. Grade 2 RDS probably. Um, but the baby's oxygen requirement just seems more than, and not responding to oxygen without having too much of distress seems to be a little odd. So let's see what happened to the baby. The baby's saturations were just not being maintained, so the baby had to be intubated, ventilated, and given surfactant. Even on ventilator, the baby needed 60% oxygen to maintain SpO2 in the preductal, that is in the right arm. uh, at the same time, they started antibiotics and IV fluids, and total hospital stay again was 14 days. The baby recovered slowly. 3 to 5 days, the baby became stable, and the baby was extubated around day 6, day 7, and then had a 2 week stay. So again, this sort of problem is typically a transition with the neonatal hemodynamics or circulation. So gas exchange initially happens from the placenta in utero, and that is switched to the lungs immediately after birth. So initially, the lungs are not really meant for oxygenating. So what happens is that the pulmonary vascular resistance in the fetus is very high, because only 10 to 15% of blood goes to the lungs. The rest of the blood doesn't need to go to the lungs because the oxygenation is not happening there. What happens is that once the lungs are expanded with improved oxygenation and elimination of the placental circulation, there is an increase in the systemic resistance. So once the umbilical cord is clamped, that is connected to the systemic circulation. So that pressure rises, and simultaneously the pulmonary pressure drops. So there are three shunts in utero. One is the PFO between the right and the left atrium. One is the VSD between the right and left ventricle, and one is the PDA between the pulmonary and the aortic artery. So broadly, what happened in our case was that the pulmonary pressures, which are high in the fetus, they did not reduce as we had expected, and the pulmonary pressures remained high, which is often called as PPHN, or persistent pulmonary hypertension. Again, it can be of varying severity. It can be life threatening if it is very severe. Most common cause of PPHN is called maladaptive, which means that there is lack of adaptation of the pulmonary arteries, which is either due to meconium aspiration or due to untreated RDS, or simple things can affect the pulmonary circulation, like babies being cold, excessive pain, anemia, polycythemia. So a lot of things affect our pulmonary circulation. So broadly, what was happening is that, as you can see here, the pulmonary resistance was very high, which leads to the blood from the right ventricle, which should have gone to the lungs to oxygenate, can't go there, and then it is shunted through this PDA as a right to left shunt. So you can see that the blue deoxygenated blood sort of goes on the left side, and then which is what leads to the cyanosis. The preductal saturation comes before this PDA, so it is preductal. So that's why the preductal saturations probably will be much higher, and the left hand and both lower limbs sort of represent the postductal saturation, which will be lower in this case because the mixing is happening at the ductal level. Hmm? So the direction of shunt is important. The echocardiography obviously is diagnostic, and treatment. There are multiple options of treatment available, but inhaled nitric oxide is probably the most evidence-based and the most safer medication to use for PPHN if indicated. So, what worsens pulmonary hypertension? Think of the pulmonary circulation as something that is very sensitive and very delicate. So, hypoxia can make it worse, hypothermia can make it worse, acidosis can make it worse, high CO2s can make it worse, any pain handling. So, that's why when the babies cry, they become more blue. Anemia, polycythemia are more, either way they are not good for the pulmonary vasculature. So we need to sort of be careful about this scenario also. And one of the key pictures of this scenario is that the oxygen needs will be much higher or out of proportion to the respiratory distress. So the baby will have some tachypnea, occasional grunt, but the saturations will be typically, between 80 to 90, and they won't be very responsive easily. So you give oxygen, it might pick up, then the baby cries, it will fall again. So that is one clue that, gives you that if the oxygen, and we are increasingly seeing this even in preterm babies. Previously it was described only in term babies, but with time we have realized that even preterm babies can have that. The second key feature about that is that the babies are very labile on handling again. So whenever the babies are touched or handled, they desaturate, and once you calm them down, then the saturation picks up. So this lability is also very typical of PPHN. Pre and post ductal difference, that is the saturation difference between the right upper arm and any of the other limbs, more than 10 could be considered as a significant pre post ductal difference, and that is again a sign that there is PPHN. But this will happen only if the shunt is happening through the PDA. Isn't about the timing. So just because there is no pre post ductal difference doesn't rule out a PPHN. And the management is mainly supportive. That means you ventilate the baby, because that will help with the oxygenation, CO2 and everything. Secondly, you keep the baby calm. If the baby can't be calm by feeds and all, then you might need sedation. Maintain good oxygenation. Saturation targets are usually between 92 to 97, 98. uh, Keep the baby well fed, make sure the hemoglobin is normal, glucose is normal, and all other parameters are normal. Once all this is done, then we look for other therapies like nitric oxide. Sometimes if nitric oxide is not available, even sildenafil is useful. Milrinone is another inodilator, which acts as a weak inotrope, but also helps in a little bit of dilatation of the pulmonary vessels. So that was the third case. Now coming to the fourth case, baby A. Uh, this baby again is a late preterm, 2.9 kilo. Mother had an acute PV bleed and a cord prolapse was noted at the time of delivery. So emergency LSES was done for fetal bradycardia. The fetal heart rate was, constantly between 50, 70. So they decided to do an urgent C-section. The baby did not cry after birth, needed positive pressure ventilation for a few minutes. But after a few minutes of PPV, the baby's heart rate picked up. So the baby never needed intubation, and the Apgar scores reported was 3 at 1 minute and 8 at 5 minutes. At 30 minutes, the baby was noted to have slightly decreased activity. The breathing seemed okay. The baby was quiet, and the SpO2 was 95% on room air. After 2 hours, the nurse tried to feed the baby because the baby was not sucking well. And the baby took one Paladafil, but not sucking actively. So it was sort of that the nurse was sort of force feeding the baby. The baby appeared slightly pale. The saturation still were very stable. There was no distress. And the sugar was also acceptable for 2 hours for a baby who's otherwise well. It was 45 mg per DL. So again, the question is that, is this normal transition or abnormal transition? When to intervene? Is it time that we start investigating this baby? Should we wait? If yes, then what intervention does this baby? Because this baby seems overall okay. There is no oxygen need. The baby, overall has been feeding with the pallida, not sucking well. So, should we just wait and watch, or what should we do? And again, if we miss a crucial window or a crucial diagnosis, what can be the worst case scenario in this? So again, the history, clinical presentation, and then we sort of think of all these four questions before deciding our plan. So let's see what happened to this baby with progression. This was an outborn baby. So at 12 hours, they noticed that the babies had like some abnormal movements, staring episodes, cycling movements. The baby again, throughout the day, the nurse was able to feed with a pallida, but the baby never had a good suck for the first 12 hours. The baby's color again looked a little off, and the sugars remained borderline. The sugars were all between 35 to 50. So there was no critically low sugar value, but again, no sugar value that was high. At this stage, they called us and they decided to refer the baby to us. Once the baby came to us, the baby continued to be dull. The seizures were frequent. We had to ventilate the baby at 18 hours. IV fluids were started, and the baby also needed some inotropes and antibiotics. Again, our concern mainly was that this was a baby who needed some resuscitation, had a seizure. So MRI was done on day 6. Uh, what we can see here is the deep gray matter, which is the basal ganglia thalamus region, and that is the hyper echoic or the bright areas that are seen. So again, this is seen in sudden acute hypoxia that the fetus had. This was probably related to the cord prolapse and the acute massive PV bleed that the mother had. So what is important in this case is the time of pathological events after a hypoxic ischemic event. So initially there is a phase of primary cell death, which happens very quickly, and then there is a latent period of around 4 to 6 hours, after which the delayed neuronal death happens. And within 6 hours is a crucial window of therapeutic hypothermia or cooling that over the last few years has become standard of care, with which the moderate to severely encephalopathic babies do much better if they receive this intervention in time. So what does cooling or therapeutic hypothermia do? So this is a Ticotherm. There are a few different devices available for cooling. Mira Cradle is sort of a locally adapted device that is commonly used. Then Ticotherm is a standard device that are there. Previously, it used to be done with ice packs also. The important thing for cooling is that we should always have a core temperature recording. So, and it should be sort of between 33 to 34 degrees. So we should try to maintain it at a constant level, because temperature fluctuations are also not good for the brain. And measuring the peripheral temperature won't be of any use, because the core temperature and peripheral temperature are also quite different. So we should always have a core temperature record, and we should try to maintain a steady state in between 33 to 34 degrees. So cooling, what all does it do? It reduces the cerebral metabolism, it prevents edema, it decreases the energy utilization of the brain, it reduces the cytotoxic amino acid accumulation, it suppresses the free radical activity, and it inhibits apoptosis. So it has multiple ways by which it uh, acts. And over the past many years, like I said, 5-10 years, it has become standard of care. There have been multiple large randomized trials on cooling for moderate to severe encephalopathic babies, and it has shown to reduce death or severe neurodevelopmental disability. So again, what is the key message for a pediatrician in this? Uh, at 30 minutes, 2 hours, again, it wasn't very clear if the baby is normal or abnormal. But having periodic neurological examinations is very important for a baby who's not, who's needed some sort of resuscitation. There is a history that is there. If a cord blood gas is available, then sending that can also, give us a clue. Sometimes the cord baby looks okay, but the cord gas comes 6.9. Again, that would mean that this baby probably needs periodic assessments and examination. So, blood gas, and any blood gas which has metabolic acidosis or lactic acidosis. So metabolic acidosis, for a HI case, we typically say that the base deficit more than -12 is considered critical. And a high lactate again is suggestive of anaerobic metabolism. So checking a blood gas. If the cord blood could not have been sent, sending a baby's blood gas within 1 hour is also acceptable. Cooling has become standard of care again. So in the Western countries, if a baby is born in a peripheral center, has signs of HI, is not cooled, and if not referred early, they are also liable. So the pediatric team caring for a baby with suspected HI, they sort of suspected it, but they didn't refer within 6 hours, which is the cooling window. Again, is a very easy medical legal case for the family to win, because it has become standard of care now. And always remember that for the brain, cooling is one part, but other brain friendly things like maintaining oxygen, maintaining sugar, maintaining the recommended temperature, and maintaining a good perfusion and blood pressure. These things are also equally critical for a baby who's at risk of brain injury or having ongoing brain injury, because these will add on to the problems for the brain that is trying to recover already from the hypoxic event. So let us recap basically what we sort of discussed in the past 20-30 minutes. In case one, we sort of discussed a case of transient tachypnea where the lung fluid clearance didn't happen. Again, the baby was not really sick, not very sick, but at around 2 hours, it was noticed that the things are getting worse rather than improving. So there could be a component of surfactant deficiency also. That should be one thought. Second thought, that why, if it's TTN or transient tachypnea, then why is the baby not improving? Because that baby also had a setup for transient tachypnea. The baby, it was a C-section. There was no labor that happened. So the mother didn't have all that stress, and the hormonal release of the baby probably was quite low. The second case, we discussed glucose regulation or glucose metabolism. In that, we should sort of keep in mind that the baby is getting ready by 35-37 weeks with that glycogen deposit. So a baby who's born earlier or a premature or an IGR baby won't have that deposit. So they will be even more at risk of hypoglycemia. GDM is a different scenario. So what happens if the mother is diabetic is that the mother's blood sugars are constantly high. So that glucose freely passes to the baby. So the baby's glucose levels in the uterus are also high. So the baby's pancreas, they secrete sort of excess insulin because they think that the baby's glucose are going to be high. So they are in a hyperinsulinemic state. Now the mother's glucose and the baby's glucose is disconnected as soon as we clamp the umbilical cord. So then the baby's sugar drop, and this insulin that is already high in the baby's blood, that circulates. That circulation of insulin, most commonly it is called transient hyperinsulinemia, that can last even up to 14 days. So till 14 days that my baby might need high GIR, high, maybe sometimes even other medications like glucagon. So again, from the brain point of view, any symptomatic hypoglycemia is not good. Any glucose level which is less than 18 is sort of also associated with poor neurodevelopmental outcomes. If it is a single value which was 30, 35, which picked up immediately, then we can reassure the family that things are okay. One of the problems with glucose checks is that we are only checking periodically. I checked at 12 o'clock, now I'm checking at 4 o'clock. In between what the glucose's fluctuation is happening, we don't know. So that is one caveat to glucose measurements, that it is not continuous, unlike an SpO2 monitor, which is giving us a real-time reading. So we should still be very careful with the glucose maintenance, especially in a baby which is at risk. So that is why these bodies like AAP and such bodies have guidelines that check at 2 hours. If normal, then check it after 6 hours. If abnormal, then feed or intervene and then recheck in 1 hour. So they have these strict guidelines mainly to see if the physician or the medical team adhere to the guideline or was there any negligence from their point. The third case was also very common. We see that one baby, with this PPHN, due to delayed treatment of surfactant or due to maladaptation, we see one case per month in Surya Hospital. The babies are usually sent on day 2, day 3. By the time they are on the ventilator, not maintaining saturations. So from the pulmonary circulation point of view, again the key messages we should remember that number one, this will always have a mostly this will have a scenario that will be either a late preterm, some RDS which was not treated. More likely, even there will be some amount of meconium or some setup of infection. So this pulmonary hypertension is always secondary. So it's mostly secondary and it's called maladaptive. The idiopathic pulmonary hypertension is extremely rare. We have probably, I must have seen one case in the last 5 years of idiopathic pulmonary hypertension. So most of our cases are secondary, either to RDS, which is untreated, or MAS, or due to some infection. So the first step is always to support the baby nicely, give oxygen if the baby needs that, give PEEP, CPAP ventilation if the baby needs that. If there is some RDS component, surfactant will help. Severe meconium cases also, surfactant will help. And antibiotics if infection is suspected. Keep the baby calm, keep the sugars well, make sure the hemoglobin is well, make sure all the other parameters that we discussed to keep the pulmonary circulation happy are well maintained. And after that also, if the baby needs more, that would be a good time to refer the baby, because then other drugs like nitric oxide or sildenafil may be useful. It should be a routine to do an echo in any baby who needs nitric oxide at least. If the baby is reaching till that stage, then we shouldn't be treating empirically. So doing a echo, and sometimes we even need to do serial echoes. Like we have done an echo, we start treatment, and then maybe in the evening or next day, we check another echo to see if the pressures have come down or not. So that was the third scenario. And the fourth scenario was a perinatal depression. Again, this is a very important thing. Currently, because of cooling, it has become even more, the onus is more on the pediatrics team and the neonatal team to pick it up early, diagnose it, refer early, and treat early. So for this, there are objective scores like Sarnat and Sarnat scoring for neurological examination, but at least the basic neurological examination will be helpful, which includes checking the baby's sucking, grasp reflex, baby's tone, and if the baby is not feeding well, looks lethargic, despite the sugars being normal and despite other parameters being normal, then we should be suspicious that why is this happening? And especially if there is any antenatal risk factor which was severe, like a massive bleed or something. And oftentimes the babies don't need severe resuscitation. Sometimes the babies will, pick up after 2-3 minutes of ambu, the heart rate will pick up, but the baby's neurological status will not be normal. So that is again a sign. And again, if there is doubt at 1 hour, that is fine. Let's recheck after 1 more hour. Let's recheck after 1 more hour. So within 2-3 hours, basically, For all these scenarios, we should sort of have a clear picture that no, this is not normal transition. Let us intervene. This will be the steps of intervention, and this is when I will refer. So these thoughts should be very clear in our mind. So again, coming to the transition problem, majority of the things we should identify and prevent. There is a vast majority where where there is easy to miss and there is delayed detection. There is a small portion of transition problems that are just not preventable, so those babies won't do well no matter where they are born, tertiary level center. So there's a very small proportion which is like a tip of the iceberg. But below that, we should always remember that there are thousands of babies which just have a normal transition. They are just born, things happen very smoothly. This is what we see 9 times out of 10. So our eyes are usually trained to just, assume that things are going to be normal. But we should also focus on this second from below box, which is the things that can be identified and prevent, and also the ones that are easy to miss. So we should be only missing this tip of the problem, which are non-preventable problems. So again, one more thing that I'll again highlight is that transition is more than the lung. Oftentimes, broadly, we think transition means the baby has cried, transition has happened, breathing has done. But we should always remember that apart from lung adaptations, the lung fluid, all those surfactant maturation, all those adaptations, cardiovascular adaptations are also equally important, if not more important. The closure of the three shunts, the physiological shunts, the switch from predominantly a right side circulation to a left side supplying the whole body, the circulation going to the lungs for the first time to oxygenate, all those transitions are very important. Endocrine function and endocrine transitions are also important, maintaining glucose, how the glucose level fluctuates and everything, and the glycogen stores, how within 2 3 hours that is induced. Metabolic adaptations, again related to maintenance of glucose and how the protein deposition, when will lipolysis happen, those sort of things. And thermogenesis, which is temperature regulation. So transition is not simply a function of the lung, but also all these other systems, they all work in harmony. So again, one more message or one more thing is that whenever one of these transitions or one of these systems are not transitioning well, we should also look for other things. So baby who has transient tachypnea, which seems more than usual, we always check a sugar just to make sure that that transition has happened well. We also check the saturations, upper limb, lower limb, to make sure there is no element of PPHN. Sorry, we also check the temperature to make sure that that transition. So transition overall is like a bundle where each and everything, when it happens smoothly like a well-oiled machine, the baby is completely fine. And if one or two problems are happening, then we should just be very alert. And the best thing for prevention, the messages are that having a watchful eye will prevent hazards. And some things can't be picked up like I say at 30 minutes. At 30 minutes, whoever sees, they might say that this looks okay or this looks not. But if there is a doubt, the key thing is to have a serial monitoring. And then sometimes pediatricians ask, so how long should we serially monitor? The answer is very simple, till you are happy that the transition is complete. So at 2 hours, if you think there is improvement, but the transition is not complete, then you should do for 1 more hour. At 3 hours, if you think that the transition is still not complete, then monitor for 1 more hour, as long as there is improvement. If there is no improvement or worsening, then we should intervene or refer. Any resuscitation needed, so crying is obviously a big big step towards transition. So any baby needing transition, we should have a higher suspicion, and also look for other parameters like glucose and all. And we shouldn't forget the metabolic, thermogenic, and other less common issues that we discuss. So sometimes you just need a good cry. So as neonatologists, when we attend deliveries, this is all what we are looking to see, that a good cry, the baby has cried loudly. But again, we should wait, see that apart from crying, are all the other things normal in the baby? Has the baby turned pink? Has the baby also started to breathe normally? Has the baby got warm? Does the baby need any further monitoring? And then only leave the baby's side once we are satisfied with the transition. So I'd like to again thank NNF for giving me this opportunity. I'm just sharing some pictures of the various institutes that I got trained in neonatology for. On the right hand side, there's KIMS, where I did my early days of training for neonatology. And then the left side is Vancouver in BC Children's Hospital in Vancouver, where I did 3 more years of fellowship. And lower down is my current place of employment, Surya Hospitals in Mumbai. So this was just to broadly sensitize everyone, because as you know, the eyes will only see what the mind knows. So once we sort of train ourselves for knowing that these problems are happening, largely we can avoid problems, because with a close, follow up is mostly all that the baby needs rather than intervention. So with time, we have realized that more and more babies just need a closer follow up, and you can actually avoid intervening, and even keeping the baby with the mother is possible as long as we periodically go and assess the baby. Hmm? Thank you.
Requested that all the families they will just like ask the questions, still no questions. Correct. That's a compliment for this very good session. Anyway, it was really nice, uh, Pillai sir. As usual, as last time, uh, short, crispy, and covering most of the aspects of prenatal transition. As you said, when the mind doesn't, what eyes can see only when what mind knows. So watchful and always like again compliment this great presentation. I would like to know what is the right time to recheck GRBS after an intervention for hypoglycemia. Half an hour, 1 hour. That was the question.
What is the right time to recheck?
Recheck the GRBS after intervention for hypoglycemia. Suppose the hypoglycemia we have
So
started.
typically, if it is, yeah, typically if it is feed, then usually we wait for 1 hour, because the sugars won't pick up very quickly. If it is an IV fluid that is so mostly we'll start IV fluids only if the sugars are less than 25 or less than 28. So we are already a little bit more worried. And IV fluids will act very quickly. So if we start IV fluids, I usually check in 30 minutes. If it is a borderline sugar between say 25 to 40 where feed was given, and if the baby is asymptomatic, 1 hour is fine to wait for those sort of situations.
Like your practical like approach, like what you are doing, like what in your institute, like which is a cutoff 40, 45, or what is actually safe zone, which you want.
So that depends on the value and what period it is. So right after birth, the AAP has given the operational threshold for hypoglycemia, which is 45. So any baby which is below 45, we are sort of watchful that this baby needs a repeat sugar check within 1 hour. And for a IV insertion below 25, or if it is between 25 to 40, but if the baby is appearing dull or looks like there is excessive jitteriness, then even between 25 to 45 we will be acting more aggressively. This usually holds good for the first 6-12 hours. Once 6 hours has passed, then there is no reason why a baby should have a sugar between 25 to 40. Then it should be above 45 only beyond the first 6 hours. So this leeway is given by AAP for the initial transition, because initially that nadir happens, induction of the glycogenolysis and other things from the hormonal point of view happens at 2-3 hours. So once the 6 hour window has crossed, normally we are only happy with the sugar above 45.
What first case you discussed, that was like distress or tachypnea. Now, like usually for the for audience purpose, like can you just in short briefly like tell like clinical aspects, like how will you differentiate like TT and RDS, meconium, pneumonia in first 2-3 hours? Any clinical clues that will guide you that this might be would turn out to be like this, something like
Yeah.
clinical clues.
So broadly, there are two ways to look at it. One way is to objectively see that how much distress is there, and based on that we decide the intervention, and that will remain same no matter what the problem is. Like if the baby needs a CPAP, it will be same. If the baby has RDS, there might be need for CPAP even for TTN. So we do objective scoring, which is either Downey scoring if it's a term baby, or a Silverman Anderson score if it's a preterm baby, and the oxygen requirement. So of all the criteria from these scoring systems, if you don't want to do the full score, at least see that how much oxygen the baby needs to maintain the target saturation. If usually that is more than 30-40%, that means that probably the baby is needing some sort of pressure. The key feature of transient tachypnea is always that the baby improves periodically. So say at 1 hour you have watched the baby, 2 hours it should be little better, or same 3 hours it should be more better, and by 6, 12, 24 hours it should sort of resolve. So as long as it is an improving picture, that is number one. RDS or surfactant deficiency typically peaks between 6 hours to 48 hours. That is the crucial window for a surfactant deficiency. So this will be a baby who is preterm, moderately preterm, or a late preterm. The mother didn't get steroids probably, or this was again a C-section. which was done very suddenly. GDM also, diabetic babies, infant of diabetic mothers also have slightly more predisposition for surfactant deficiency. So if there is these clues in the history, and if the baby is born and there is significant distress, then the baby probably has RDS. The X-ray pictures of RDS are having a air bronchogram, and having whiteout lung obviously is a severe RDS. Uh, but on the other hand, also that mild RDS and minimal things may not need surfactant. So with CPAP only, we might be able to tackle with some RDSs. Again, for infection, there is a predisposition, like there is antenatal, leaking more than 18 hours, or maternal fever, signs of chorioamnionitis. So that history will give us a clue about the different scenarios. 12.9 continues. SSPT. No, mathematics.
Yes. No more question. I think like only this just basic core line, like you should be more watchful and pick up early signs most of the time and intervene. Be aggressive also in starting the treatment and even weaning both the time. That's what is cross of not like even the transition also it's the same thing. Any doubt, better to admit as you said, or better to like at least act and evaluate. Okay, there is one more like Dr. Amol is asking is please comment on SUPC early marker.
Sorry, what early markers?
SUPC. Amol sir, just like again, like this, what is the long form this SUPC? Just I'll ask him something like something new for me also, like sudden unexpected collapse. Sudden unexpected collapse, he's saying.
So there
Any
are
comment
no
on
early markers for SUPC or SIDS. There are in the West, it is a huge thing. SIDS, like you will find articles and chapters in books about sudden infant death syndrome. We know some risk factors that predisposes babies to it, but from a baby's point of view, there are no risk factors that can predict. Otherwise, it wouldn't be called SIDS or sudden unexpected thing. If we could have said that if these babies are there, so typically from the preterm or the as a neonatologist we feel that babies who are preterm, or babies who are needed oxygen for very long time, they can have sort of apnea till 44, 48 weeks, 50 weeks. So that could be one risk factor for that. Apart from that, the risk factors are broadly general, like maternal smoking, or a mother co-bedding with the baby and the mother, or maternal education status, teenage pregnancy. So a lot of epidemiological data is there about SIDS in terms of what was the association, and this association was higher, and they have given a bunch of risk factors. I think there are 25 odd risk factors that AAP has given, but none of them pertain saying that this, if the baby has these symptoms means he will probably have SIDS in the future. Essay, there is no clear cut answer. So there are no early signs basically, if that was your question.
basically we detect it suddenly, okay. Rather than baby suddenly deteriorating, we detect it suddenly. The baby will give some ample amount of time, some clues, signs, symptoms that yes, baby is going to deteriorate. And it's we who detect actually late. That's what I have observed. Like,
Hmm.
it's okay, fine.
Yeah, yeah. So
So
normally, and SIDS is very uncommon. So 90% of the babies, there will be some signs where, like Dr. Sunil was saying, where we can pick up that, okay, this baby is not doing well, not doing well.
except for
And
something like
then, so that is not truly a SIDS. That is,
except for something like IVH, which occurs like this really suddenly, we can say, like, or a little fast progression. Rest of the other thing, most of the thing, like they will be progressive. Maybe it's like sometimes progression may be fast, but to have sudden thing, like it's only like conversion or seizures or IVH, that only things are will be sudden. Most of the things will give some time for you to detect or some signs symptoms will be there. Okay. No more questions, Anish sir. But anyway, I lucid, like very clear and very to the point, very practical again, as like last presentation. So thank you everyone. Thank you all the delegates here joining on this weekend. And again, we'll have some one more practical lecture next time, mostly related to developmental early interventions or developmental follow-up. So thank you everyone again for joining here and asking questions and being interactive. Thank you, Anisha.
yeah,
Thank you.
thank you.